imaging and how to take it. So just feel free to unmute and interact if you so wish. I'm going to start with a case where you can see the LAD. There's, before the contrast comes in, you see some calcification, you see long diffuse disease, and potentially some tapering at the distal left main. Not really sure how significant that is, and the right coronary looks okay. So, we want to quantify or decide how significant this left main is. FFR was done, and as you can see over here, the FFR in the mid-LAD was actually 0.7, and on pullback, when we were back into the left main, it was 1, suggesting that the left main was actually not significant, and we could leave it alone and address the long segment in the LAD. But that tells you about the functional value or significance of the lesion that you see in the LAD. It doesn't really tell you how significant that calcification is, if we need to do any kind of atherectomy, and so on. So we went ahead and did intracoronary imaging with optical coherence tomography. What I'm going to do is walk you through it very quickly. And I'm just going to pause where it's significant. So I'm going to pause right here. And what you can see is from around 10 to 12 o'clock, there's some calcification. And if I just keep scrolling, you're going to see more calcification in that area. But it's not a very big or a very large arc of calcium. You see the bifurcations coming in of the branches, whether it is the septal branches or the diagonal branches. And you keep going, and you don't see a whole lot of calcification. You do see some fibrotic tissue and interspersed fatty tissue. And here again, about 4 o'clock to 5 o'clock, you see some calcification. And we keep going to the rest of the vessel. So this was the segment that we interrogated by optical coherence tomography. So what do we want to do with imaging? So we want to do something pre-PCI, and then we want to do something post-PCI. And although I'm going to focus on OCT, but intravascular ultrasound is very similar, and we still look for the similar parameters. So we want to look at morphology. The first thing we want to look for is calcium, because we want to make sure that our patients are not requiring any form of calcium modification before we put a stent and then it becomes underexpanded. And we also want to look at high risk, and we also want to look at some high risk plaque features. So we'll go over some of this in a moment. And then we want to look at this lesion itself. We want to determine the length of the lesion, the diameter, the reference diameter, so we can select an appropriately sized stent. And so, when we're looking at morphology, it has, as I mentioned, procedural implications, bringing in the bigger guns, rotablation and so on, but also assessing high-risk plaque features in patients who come in with PCS and so on, and you can't identify a culprit. And then the stent sizing and identifying landing zones. So when we look at lipidic lesion, for example, you can conceivably just do direct stenting without pre-dilatation. When you look at fibrotic lesions, you probably do want to do some form of dilatation, either a compliant or a non-compliant balloon. My go-to is usually a non-compliant balloon. And then you look at the calcification, how significant is it? Is it mild? Is it moderate? Is it severe? And, as we get to more severe, as you see in the last frame over here, this is more than 180, closer to 200. And you want to look at the thickness and the depth, and we'll get into it in a minute. You probably want to be considering atherectomy or IVL. But intracoronary imaging is about pattern recognition. So you need to see it again and again and again. It's a bit like when we were medical students, and then when we were doing our medical residency and cardiology fellowships and looking at EKGs. You can read theoretically about EKGs and about rhythm issues, but it really is, the comfort comes from pattern recognition, and so repetition, repetition, repetition. So you can start distinguishing between them. But here's the theory. So when you're looking at a fibrotic lesion, it's highly reflective. It tends to be homogeneous and has fine textures. And when you look at the lipid-rich segments, so the middle frame is actually lipid-rich, you see low reflectivity. It's very homogeneous, and the margins are actually very diffuse. So compare it to the first image where it's fibrotic. And I know a lot of people tend to confuse those two. But then you also want to look at calcified lesions. And when you're looking at calcified lesions, again, their low reflectivity is low. They tend to be sharp margins and heterogeneous. but you need to see it over and over again. And the reason I'm saying you need to see it over and over again is, one, in any given vessel, you are going to have multiple morphologies. But even in a given segment, you're going to have calcium in one area and potentially fibrotic lesion in the contralateral wall, and so on. So you need to get acquainted and comfortable with that. It's not an either or. So when we look at the calcium, how do we quantify it? Well, we want to look at whether it's superficial or not. So superficial, it's closer to the vessel wall itself, to the lumen itself. It's not very deep. You look at deep calcium, where it's actually much deeper than the intima. And then you want to look at nodular calcium that's actually encroaching into the lumen. And then you also want to see whether it's concentric or eccentric, as you see in the two bottom images. And then there's this rule of 5. So you want to look at the thickness, that it's more than 5 millimeters. The arc of the vessel is more than 50%. And then the length, that it's more than 5. So that's what we usually use. And there's different scoring systems and so on. You want to see which scoring system you're comfortable with. And I think the rule of 5 is just easier for me to remember. So it just becomes a lot more practical. So for intravascular ultrasound, it's still very similar, but you do need to train your eye again. So once again, if you look at this initial image, you look at 270 degrees. And so you want to look at the degree of calcium. And again, you see a lot of bright calcium, and then below it, there's shadowing. When you see shadowing, you know that that's calcium. As opposed to 360 degrees, as opposed to a nodule that's encroaching, and then something that's impacting the vessel. And so this is another published scoring system based on intravascular ultrasound. And if you start to get a higher score, you consider atherectomy in those patients. So back to our patients. So when you see the yellow, this is what we have. We don't really have much calcification over here. This looks a lot more like a fibrotic segment. And as we come back to the red segment, what we do see is actually a calcium arc that is about 180 degrees. It is 0.5 millimeters in thickness and 5 millimeters in length when you look at the longitudinal view of the intravascular or the OCT, optical coherence tomography. So we opted for cutting balloon in this case. Again, no calcium, so no specific plaque modification was required there. And landing zones. So now you're going to modify. You know that you need to do some modification, but the next part of the assessment pre-stenting is actually looking at an appropriate landing zone. And you want to go from a segment that's completely normal if possible, but remember, we're now treating very sick patients. They can be diabetic, they can be patients who have hyperlipidemia, chronic renal disease. So you may not see a completely normal segment. So you need to be as close to normal as possible. So either normal or a fibrotic lesion. Again, and as you calcified, you're starting to get into the less suitable. But lipidic is really not an ideal place that you want to be parking your stent, because your risk of adverse events and your risk of, dissections, stent thrombosis, restenosis is much higher. And of course, periprocedural myocardial infarctions all significantly go up as you move to a less suitable segment, particularly a lipidic zone. So how do we guide stent sizing? Stent sizing is you look at EEL to EEL. So if it's EEL to EEL, let's say this is 2.7, so you can round up for this particular patient. So sorry, you're not going to round up, you're going to round down. So you downsize for EEL. So 2.7 in this segment and 3.8 here. So you're going to probably come down, right, when you select your stent size. If you can't appreciate the EEL very well, so what you're going to need to do is just take a luminogram, right, and just look at the lumen and get your measurements at the lumen. And in this case, you're going to probably take it as is. You're not going to downsize at all. And then you're going to need to do proper assessment post-procedure to make sure you don't need to expand it more. So the distal reference, as you see over here, was 3 millimeters. The proximal reference based on lumen that we got was 3.1 millimeters, and then the stent length was 38 millimeters. So a long stent needed to cover that entire segment. Okay, so as you see, that was EEL to EEL, and this is lumen because we couldn't really appreciate it and went for a luminogram. So here you see the wire protecting the diagonal. We went ahead and deployed a stent. did the post-dilatation, and then did OCT again. So what are we doing now that the stent is done? What are we going to look for? We're going to look for post-implantation of a stent. You want to look for medial dissections, apposition of the stent, and expansion of the stent, right? So when you look at the EAPCI optimization criteria, there's several nice reference publications. There's one that we did with the ACC, Interventional Leadership Council, with AJ Courtenay and Alex Truesdell and so on, that again had a lot of examples, and I would reference you to look at it. So you want to look at the expansion, edge dissection, apposition, and plaque burden where you actually ended up parking your stent. So you want to make sure that your expansion, 80% at least, but ideal is if it's 90%. And then you want to be in a segment that has no lipid pool, as we agreed, and the plaque burden there is less than 50%. And then you want to make sure that if there is an edge dissection, what is actionable? Is every edge dissection actionable? Probably not. And there are certain criteria depending on which document you're going to actually read. Effectively, if it does reach the intima, so it's quite deep, and if it's longer than 2 millimeters, others use a cutoff of 3 millimeters in terms of length, and then you have a flap that's over 60 degrees, you probably want to cover that and tack it up. Note that these are very specific numbers that we're giving. And if you can actually see it angiographically, if you can see turbid flow or haziness around an edge stent, that's probably a very significant dissection. So a lot of these are ones that the data that we have, that we based these criteria on, or at least that these consensus documents could base their criteria on, are really, there's a selection bias. So these are patients that they actually saw, ended up doing imaging, and were able to quantify the apposition or the dissection and so on. And so in general, it tends to reflect higher event rates, but it's not, rocket science. So this is an example of the same patient where you do see significant malapposition, right? You do see, like here in the right image, you do see that the stent struts are effectively floating in the vessel. And when you look at expansion, so after you want to look at expansion, some of the devices now have artificial intelligence built in, and they automate it and they give it to you. So you can see, for example, the expansion is 77%. So you do want to expand it a little better. And you do see a little bit of dissections that are now tacked up with your stent. So this is looking at dissections. So now you want to look at the dissection, see how far. In the longitudinal view, you'll see how long it is. Is it more than 3 millimeters or not? You want to see if it's going deeper into the intima, and so on. So these are different dissections in a different patient, not this particular patient. But then we went ahead, used a higher balloon, bigger balloon, 3.5, and then this was the final angiogram. Looks good. And then the OCT actually, I'm not sure if I showed it in a previous image, but actually showed better apposition. So these are the criteria that we need to remember. I recommend that you have them in your cath lab, have it accessible until you become comfortable with it. And as I said, so the one I showed you based on the APCI looked at 60 degrees, looked at 2 millimeters. This particular one looks at a malapposition of 3 millimeters, significant 0.3 millimeters from the wall, and the length being more than 3 millimeters. Again, looking at the dissection where it penetrates the media, extending beyond the intima, and actually first quadrant, one quadrant of an arc. And then the expansion, you want to see acceptable is 80%, but more optimal or ideal is more than 90%. So I'll go over some cases now and see how much of this we've retained. So this is the right coronary artery of a patient. You can see a very stenotic segment, a lot of calcification even before the contrast is injected. And you see a nodule that is appreciable by optical coherence tomography, because now it's encroaching on the lumen. It's no longer just embedded in the wall, the calcification. So what therapy was used here? So this is the optical coherence tomography that was done after the therapy was done. So you kind of see a little bit of it. It was a combination. So there was orbital atherectomy or Diamondback CSI plus shockwave and ballooning. And in the OCT, what you see around, between 5, 6 o'clock is the fracture. And you do see that we shaved off quite a bit of that nodule and created more lumen gain with the orbital atherectomy. And so then this is the final angiogram, and you see the stent that is well expanded, well opposed. The concern of not using atherectomy in some of these lesions is, I'm going to go back to just a couple of slides to this slide. If you keep just trying to use a post-dilatation balloon and high-pressure balloons, and now we have a lot of high-pressure balloons, the place that this is most likely going to yield is at the junction between the normal or semi-normal tissue and the nodule itself. So I'm not sure if you can see my arrow that I'm using it to point, but it's actually going to be at these edges. So you may actually end up having, fractures there, and with more dilatation, it just keeps yielding and yielding until you get perforation, but the nodule hasn't been modified yet. Right, so I'm going to keep going unless somebody stops me. This is another case.
Keep going. Yep. This is great. Well, actually, maybe let's stop with the nodule just a second, because I always think it's great discussion, nodules. Because to me, I've got to admit that nodules are probably the bane of my life when it comes to coronary. Because I feel like I can treat just about everything else, and then comes the nodule, which is, protruding, and I never really know what to do. And I always try different things. I try rote, if it's, protruding enough. I try orbital. I usually use a combination of, atherectomy with cutting, or atherectomy with shockwave. But even shockwave, sometimes it's great, sometimes it's crap. So yeah, what is your advice for the fellows about what you do?
So nodules are very tricky because there are actually two types of nodules. So one is the nodule that I just showed you, which is a very stable nodule and is almost like probably going to present as a chronic coronary syndrome. And then there's the eruptive nodule. And I'm going to show you an example in just a moment of what an eruptive nodule looks like. And that's usually a more active process that's happening in that lesion. So there's fractures that have happened, hematoma into the wall of the vessel and into the wall of the nodule, and then it just continues to expand and potentially can eventually thrombose the whole vessel.
Right.
The problem with nodules is they're just so dense that whether it's with IVUS or with OCT, you really can't interrogate what happens beneath it, which makes it very difficult to anticipate which modification tool is going to actually work for you. What I've been doing is using exactly what you just said, is combination. So shockwave just tends to, in my opinion, a little bit like laser, it makes it softer and more susceptible to the next technology that I bring in. But I don't think it modifies it enough. The next thing is to bring in something like either orbital atherectomy or rotablation that actually starts to do a lot more shaving as it's going along, and just removing some of that content that is there that hopefully was already slightly fragmented by the lithotripsy. The difficulty with very tight lesions like the one that I just showed you is sometimes you need something else first to be able to deliver the lithotripsy and to be able to deliver a cutting balloon. So sometimes the order of which you do it is very different. So I don't think there's a definite science for it right now, but I think what seems to work most is combination therapies for calcified lesions. So this is another calcified nodule case. And as you can see, you're starting to see around 9 o'clock to 11 o'clock some deep calcium. It is also quite superficial. It's starting to come very close to the surface of the vessel. And it's not just deep, it's a very thick calcium that hasn't yet encroached on the lumen. But guess what happens next, right? So now I'm moving further. So if you come back here and you see the marker here, it's, a little after 30, the 30 mark. You keep moving, it's moving a little further, a couple millimeters more, and you start to now see at 11 o'clock, that's the wire. Right next to it, 9 o'clock onwards, you do see the calcium now protruding into the lumen. And then if you look at the right hand, I'm moving even further into the vessel. So you see I'm coming closer to 35, and you now start to see this eruptive nodule that is definitely encroaching on the lumen even more. It's right next to, coming closer to touching the catheter that's in the center, and right next to the wire that we have in there. So this is the lesion as we keep going. So you see I was around 30, 35, and now there's a second nodule that's around 40, 45 that's protruding between, 11 to 1 o'clock almost. Again, right next to the wire over there. And as you keep moving, you'll see more and more of that. So this is an eruptive calcified nodule. And these tend to be less resilient than the other nodules. So they've already gotten some fissures. So these, I would try cutting balloons here if I can deliver them. I would try in these because they're just not too soft, but they are softer than the nodule that we saw that was totally calcified. And remember, again, you want to be doing imaging in between, because where it will tend to fracture is at the edges, where it's junctioned with the normal vessel. And then you see that there are different patterns of calcium in this one patient. So it's not just the nodule that we saw here, but in the same patient, there's some superficial calcium that you're seeing up there. And in the bottom, you see both superficial and deep segments of calcification. And you do see here a 270-degree arc of calcium. So it's going from around 11 o'clock all the way around to about 7 o'clock. And you see the depth of the calcium, it's quite deep. So it would require some kind of atherectomy. So I'm going to move on from calcium to something else now. And again, please feel free to unmute and just pose questions, because I can't really see much.
Sure. No, let's go ahead. And that goes out to the fellows or any other faculty who've joined. Please, if either put up your hand or put a question in the chat. I think it'd be nice to make this lively. Thanks.
So this is a patient who came in with an acute coronary syndrome, really unstable angina. There's a lot of proximal disease, as you can see over here in the LAD. We went ahead and did intravascular ultrasound. You see the top OCT frame. What you do see is calcium from about 12 o'clock to 9 o'clock, where the wire comes out. That's just wire. You see another segment of calcium that's a little deeper in the middle screen, probably from 11 to 1. So it's not a big arc of calcium. And as we go further down, and again, the bottom shows you where we are in the vessel. So we're before 20 mark, then in the middle, we're in the 20 mark, and then much further down the vessel, and you see a fibrotic vessel over there around after 50. So we decided that this patient probably does not need atherectomy, but will need long stents because we see the segments that are actually diseased. And we started to dilate, and you can see here that there's a waste, although this was not the calcified segment, this is fibrotic. So the fibrotic does need sometimes modification. You may need cutting, high pressure balloon, and so on, until it finally yielded. And then we went ahead and started stenting. But before stenting, we need to do an intravascular ultrasound run, OCT run. And what I want to show you here is the top one actually shows you that we did, there's dissection, right? And it's facing 9 o'clock. But you see that it's quite extensive. If we had pushed it any more, it would have been deeper. You look at the middle segment, again, that shows us that we've done adequate modification, but it's actually quite a deep segment that we ended up getting a fracture in it. And again, as you go down, you see that we fractured. So that one was around 12 o'clock. And as we go further down, you see this was around 1 o'clock. So we were very aggressive in this fibrotic lesion with the modification. And we now know we can safely expand a stent there. So what we ended up doing is placing a stent, and you can see we're placing a stent in cranial view to cover that entire segment. Then we moved to just make sure the proximal segment were at the landing zone of our choice. We moved our camera, the tube, and now we're in the RAO-caudal view, and we placed the second stent. And then again, what we did is we did an optical coherence tomography because we want to see how well expanded and opposed we are. So I took some still frames because it was a very short segment, but I can tell you this is how we picked it up, especially when there's a little bit of calcification, especially, you know, you're not exactly zoomed in. We're trying to use fluoro a lot more nowadays to minimize radiation and so on. But look at the mistake that we ended up doing. So this is a proximal segment of the stent. Oh, it's lovely. It's well expanded, well opposed. We don't see any issues. We come to the middle of the vessel, this red one, and you see no stents. But you do see our fractures, right? And you do see the dissections that we've created. And then as you keep going down, you see now more stented segments. It looks beautiful. It's expanded and opposed. But we have a gap between the two stents. We moved we moved the II from REO-cranial to REO-caudal. It foreshortened things for us, and we ended up having a very short gap. And I'm going to see if I can somehow show it to you here. Yep, right there. So if you see the image that's running, we're looking at the stent, but then there's no stent, right? So you see stents around 4 or 5 o'clock, and you then don't see any more stent struts. So it's a very tiny, short segment where we have no stent struts that we're covering right here. See that? And then we come back and we get our struts. So imaging actually helped us identify just a few millimeters of a gap that were actually very diseased. Angiographically, we couldn't see that. We didn't really see any turbulence, any problem with the flow. What we did is we ended up picking it up by OCT. And so that's what we're doing now. We're using stent boost. You can see a very tiny gap between them. Took an 8 millimeter stent to cover that gap and post-dilated, and actually ended up looking fine. And we did a final angiogram, final OCT run as well that showed the overlap segments. So those are things that you can pick up with imaging, but you need to train your eye and you don't need to rush it. And automation can miss some of these issues. So this is another favorite topic of mine. This is the patient, as you can see, a very ectatic left main, but really a bifurcation disease of the LAD and diagonal, which was a very generous diagonal. We chose to do DK crush. So this is an imaging session. It's not really a DK crush or a bifurcation session. We did our 2-stent strategy. This is the final kissing inflation, and then we're positioning our balloon for proximal optimization to do the pot. And then went ahead and did our intravascular ultrasound. You see the distal LAD with intravascular ultrasound is nicely opposed and expanded, but we see the segment where the branch is, the crush was not very complete. So we had to actually go back, fix it, and then at the end, you see really nice circles over here in the middle screen with the IVUS that actually show you the diagonal branch ostium. You see the LAD ostium, and just really looks nice. And you look at the proximal LAD as well, well expanded and opposed stents. But this is post, right? So post for bifurcation to tell you if you've done a good job, if you incomplete crush and all of that as you're doing the process. But this is another patient that actually the LAO or the spider view shows you Medina 111 lesion in the distal left main, ostial circ and ostial LAD. Now these vessels are very diseased. And so identifying a landing zone is an issue, but also sizing it. So the left main, especially if you're going to plan a 2-stent strategy, let imaging help you. And I know the bulk of my presentation focused on OCT, but let's look a little bit carefully here at the IVUS, because IVUS, especially high definition IVUS, can be very helpful. So when we do a run into the circumflex, so 2 runs, one that goes from the left main to the circ, and you look at your proximal reference diameter based on EEL, because you do see the EEL nicely. So you see this black shadowing. You can measure very carefully and accurately. So we've got a proximal reference diameter of that generous left main of 5.5, distal left main, you see the disease and minimum lumen area of 2. You keep coming to the ostial circ, proximal circ, and mid circ, and identifying a reference diameter in the circ and in segment that appears as close to normal as possible. And the EEL, again, is very measurable. And so we measure it and we're able to pick it. Then we do a second run into the LAD with the same intravascular ultrasound. We compare the reference diameters that we're getting. We're seeing the left main, distal left main here a little better with the angiogram, but we've already got our images from IVUS. And again, you keep going from distal to proximal of the LAD, and you see the disease burden, but you also can identify the references that you need. A distal reference diameter in the LAD and a proximal reference in the left main, and getting the total length of the lesion and how much stent you need to put in there. And based on that, you strategize. So based on that, we decide based on the numbers that we got. So we got a mid-LAD EEL of 2.7. So that was the stent that we chose, 2.5. So remember, we downsize. Prox LAD 4.3. So we decided with a 4.0 stent, and we're going to crush and kiss with a 4.0 balloon. The circumflex, the EEL was 3.3, so we're looking at a 3 millimeter stent. Prox LCX 3.9, so again, we go down a size, and it's 3.5 for the stent and the kissing. And then likewise, in the left main, we're looking at 5.2 to 5.5, so we know we're definitely above 5 here. So we're going to look at a 5.0 crush and 5.0 balloon to pot. So somebody was asking about using medicated or drug-coated balloons in the presence of calcium. I don't know how they work in the presence of calcium. I think depending on how much calcium, I would say if there's a lot of calcium, drug-coated balloons probably don't do a whole lot. I mean, they work. Calcium needs modification, needs atherectomy, needs to be removed, not only to deliver the stent, but once the stent is delivered and in position to make sure that it's expanded and opposed. I don't think that's the purpose behind or the mechanism for drug-coated balloon. It's the coating rather than the pressures that you go up with. Just like IVL, it's not really the pressure that you go up with the IVL, we go 4 or 6 bar. It's really the shock waves that end up penetrating and modifying the calcium. So this is what we ended up doing post-stenting. So when you post-stent the patient, you want to be able, this is post-stenting, you want to see that the ostium of the left main was covered fully, and we appreciate that in the bottom screen. You keep coming back and you get a lumen area of the left main. We got a 13.6. Distal left main, you want to see the apposition, you want to see the point of confluence. The point of confluence, you see the circumflex ostium very clean and nicely opened. You keep going to the ostial LAD, and you want to look at the overlapped segment of 2 stent layers. And then we keep going down until we see the distal edge, which is a little hard to appreciate here, but I think it's because it's a reproduced image and it's a little too bright. But that is actually how you do it. And for complex lesions like bifurcations in particular, I think IVUS is very handy. I know OCT can be a little challenging, although it can give you a lot of detail on where you crossed, your wire crossing, and so on. But I find IVUS very useful in bifurcations and simple to use, and I find it as well for CTOs, but that's what my colleagues tell me. I don't really do it. So I can go over some quick data, or we can stop for a minute, and I'm not sure if we're running out of time.
I think we have a little bit of time. I think if you wouldn't mind going over the data, it's always a good reminder for everyone. So yeah, if that's okay with you.
Yeah, absolutely. So I'm going to go over these really quickly. I mean, I know you
Perfect.
see eight slides here, but it's 8 listed here, but it's not going to be anything long because, as I said, the data, the evidence is there. So the ultimate trial, initially we got our 3 years outcomes, and clearly you see here that target vessel failure was significantly higher in the angiography alone compared with intravascular ultrasound. And this was in the 3-year follow-up, and it meant stent thrombosis and target vessel failure in these patients. And it was not limited to left mains, it was not limited to bifurcations. It was, essentially an all-comer trial. Renovate Complex is, however, a study that looked at complex lesions, and it was presented last year and published last year in 2023. So you do see a 36% relative risk reduction between angiography alone and image guided. And they did include in this complex lesions left main vessels, they included bifurcations, they included calcified vessels, and so on. And so here now we're starting to see robust evidence continue on with more complex lesions. The IVUS XPL, again, the 5-year outcomes, you see that initially between 1 and 5 years, definitely angiography had more clinical events in terms of death, myocardial infarctions, and stroke. At 5 years, you see that gap widen even more, and it almost doubles the event rates at 5 years. So the curves continue to diverge in the IVUS XPL, which again really looked at very complex and long lesions and IVUS evaluation of these patients with clinical endpoints. Most of these trials, the design was to make sure that if IVUS use pre-procedure was not mandatory, but post-procedure it was for all these trials. And now looking at the XL trial, the XL trial that was the whole idea of using PCI for left main is reasonable and non-inferior to CABG. They did have a sub-study that actually looked at intravascular ultrasound uptake in these patients. They looked that patients with small MSA had higher event rates compared to those who achieved a large minimum stent area. So you're going from almost 20% to 9%. So you're almost doubling the rate when you achieve a larger MSA as opposed to a small MSA in the left main. And again, you're looking at very important hard endpoints of death, MI, and stent thrombosis, and these were 3 years outcomes. And then we look at the next was the impact of IVUS on what the clinicians actually ended up doing. So 52% had IVUS. Of those, 76% ended up getting stent optimization after they used IVUS. 11% went from provisional rather than an upfront 2-stent strategy after they did the IVUS. And 9%, it was the other way around. They went with a 2-stent strategy rather than a planned provisional strategy when they ended up using IVUS. So it really does change what operators end up doing in the cath lab, particularly for something like a left main. The next trial was the Nodule trial, and unlike the XL trial, Nodule investigators did not find that PCI was comparable to coronary artery bypass grafting in left main vessels. However, when they did use IVUS and they did a sub-study and published it on IVUS, what you do see is that target lesion revascularization was actually higher and significantly higher in the angio alone versus IVUS alone, IVUS guided PCI. And so that is significant. And it warrants pause that maybe we should be looking at or redesigning left main trials that actually look at IVUS guided PCI compared with CABG rather than IVUS alone, that angio alone compared with CABG. And then again, you see this is a publication that was done more than 10 years ago by Dilatori that showed a very significant difference in those who had angio alone versus IVUS alone. So we've gone through randomized trials. This is observational data, but you see significant reduction in stent thrombosis and event rates with these patients. What's in the pipeline? Well, in the pipeline, there's the optimal study. They're planning to recruit 800 patients, 400 in the IVUS and 400 in the angiography guided only, and they're going to look for hard endpoints. I think what we also want to be looking at is looking at different ethnicities, looking at women compared with men. We do know that there's sizing differences with different populations. Moving very quickly now to some of the OCT evidence. So the October trial, this was again presented at ESC about a year ago in October last year. So they looked at complex patients who had bifurcations and had OCT guidance compared with angiography guidance alone. And it was 1-to-1 randomization. They looked at MACE at 2 years. And defined by cardiac death, ischemia-driven revascularization, target lesion MI. And again, you see a very significant difference between angio alone and OCT guided PCI in over 1,200 patients. the Illumian-4 trial, the rationale for it was that the Illumian-3 had shown that there was better stent expansion with OCT guidance compared with angiography guidance, and there was less malapposition and less major dissections. And so Illumian-4, the basis for Illumian-4 was that they want to see now if that translates into clinical events. I think we know that it did not, but high-risk patients were included, including those with diabetes, non-STEMIs, STEMIs, CTO. So you can see they really took very high-risk patients and enrolled them in Illumian-4. There was an imaging endpoint and a clinical endpoint and a safety endpoint that was not necessarily powered, but the two primary endpoints were, and again, randomized to OCT versus angio only. And they ended up with over 2,400 patients. The minimum stent area that was achieved, again, similar to Illumian-3, they were able to get better stent area in the OCT guidance than compared with the angio only, and target vessel failure at 2 years was not statistically significant in this group. In terms of safety, there were fewer angiographic complications with the OCT guidance strategy, bigger stent area, and so on. So as anticipated, and you can see it over here, these are the Kaplan-Meier curves for target vessel failure. So numerically, angio was higher than OCT. Complications significantly lower in the OCT compared with angiography. And the conclusion is you'd still get larger stent area, better safety with OCT, and hence reduction in stent thrombosis, which is a potential complication at 2 years, but it did not reduce the 2-year target vessel failure compared to angio alone. And, you know, we can get into why that is, and I'm sure you probably already discussed it in your. And finally, there was the meta-analysis that was presented by Greg Stone again at ESC last year. It was a real updated network meta-analysis that integrated data from Illumian-4, October trials, and everything else that came before it. And the analysis looked at the overall effects of IVUS and OCT, so any kind of imaging, in improving outcomes. And it looked at IVUS versus angio and OCT versus angio, and then IVUS versus OCT. 20 randomized trials, 12,000 plus patients were included, 7,000 were randomly allocated to IVUS, and 5,000 to angiography alone. So sorry, 5,000 were allocated, 7,000 were allocated to intracoronary imaging, of which 3,000 plus were IVUS, 2,000 plus were OCT, and 5,000 were angio only. And they followed them up between 6 months and 5 years. I think this, Dr. Scotty, I see your hand is up. If you kindly unmute yourself, yeah.
Hi, Mirvad.
Hi, how are you?
You hear me? First of all, thank you so much for giving us another talk here at Montiart. It's so nice to see you again. Actually, I had a question for you now that you're finishing with all the evidence here in the literature. I wanted to give us like a comment, just a quick comment on the PREVENT trial just presented and published at ACC. What's your take on this study? What about vulnerable plaques? How can we use imaging? And what do you think about this study?
Absolutely. So I'll comment on the PREVENT just very quickly. I'll finish this one off that Greg Stone had presented. And basically what it did show is that intravascular imaging, be it OCT or IVUS compared with angio alone, is actually better than angio alone. So I think it emphasizes that get comfortable with an imaging modality, adopt it, use it. It's always going to be better than angiography alone. And so, you know, the PREVENT trial is very interesting, and I'm seeing already all kinds of comments on it about looking at patients who have an ACS and then looking at other lesions. So you're looking at non-culprit lesions and trying to determine their significance and whether you need to PCI them, revascularize them or not. And what they did is they looked at certain vulnerability criteria based on IVUS and certain on OCT, and they saw that the clinical endpoints were actually better when imaging was used to identify these plaques, but also to treat them with percutaneous revascularization, so with stenting and PCI. the messaging that I'm hearing is that also now we need to be doing, not just complete revascularization, but even lesions that can be 50% and so on. We need to be treating those with stenting. So I think that the PREVENT trial is really telling us two things. It's not telling us to do that for sure. I think what it is telling us is we need to adopt intracoronary imaging more to evaluate plaques that coexist with the culprit lesion and identify and determine whether they are vulnerable or not. And then if they are vulnerable, to go ahead and treat them. So with the uptake of intracoronary imaging being very poor, I don't think we're going to end up, we're in a position right now where everybody's going to be stenting 50% lesions. And the other thing is about looking at these lesions and doing physiology and the role of physiology. I think that's the second thing that PREVENT is telling us, that physiologically, this lesion may not be showing flow limitation. It may not necessarily be stenotic and quote unquote significant. Its significance may come from it being vulnerable and hence prone subsequently to have a plaque rupture there and so on. So some of the criteria, for example, in OCT is thin cap fibroatheroma. The thinner the cap is, the more likely that it will rupture at some point down the line. So that may not now, if I do throw a wire in there, may not be stenotic or physiologically significant. So I think that's what folks are starting to confuse with the PREVENT trial. But in my opinion, it's an important trial that's teaching us to take it to the next frontier. We do need to start addressing the vulnerable plaque. We need to agree on definitions for vulnerable plaque, and then what to do with it. Is it medical therapy and LDL reduction and potent antiplatelets only, or is it also stabilizing it with a stent? Azim, your thoughts?
Yeah, no, I completely agree with you. I think it's very easy, and we have to be very careful about PREVENT and not not putting into our practice incorrectly, because also, there wasn't like PCSK9 inhibitors, being used to a large degree. I mean, we have such great medical therapy as well. And so I'm not sure if you did very aggressive medical therapy, would you get similar outcomes, right? I think it's important because we've been for years trying to figure out what to do with vulnerable plaques. Can we identify it, and can we modify them in a way that is clinically impactful? But I think before we start going to put stents into 50% stenoses or less, we have to be really sure. I think we just have to take a little bit of time. I mean, we just got the PREVENT data now, and spend a little bit more time looking at it more carefully before putting it into our practice, because I think there is the risk that some people are going to say, oh no, let's just do an OCT. We don't have to bother to do FFR or anything. We'll do OCT or something like that. And if we see any plaque there, we're just going to stent it based on PREVENT, right? And I think that would be wrong and incorrect, because we've seen how unnecessary stenting also can lead to bad outcomes. So I have lots of questions I want to ask, but before that, it's more important the fellows. So I wanted Antonella actually to ask a question. Antonella is one of our research fellows who's working with us.
Hi, good morning. Hi,
Good morning.
Mirbat. I'm Antonella.
Hi.
I really admire you because, I was just telling to Azim, how is she doing? She's so young. She's basically everywhere talking. You have been super didactic.
I'm not as young as I look, so yay, good genes.
I can see you like a model. One question was like, if you can imagine an hospital or a place where you don't have unlimited access to these technologies, what do you think in your daily practice is the most important issues that this technology let you solve? Like, for example, do you think that OCT is more useful for you for plaque characterization, or to define the landing zone, or I don't know, to say?
I think that's a fair question, and there are places where it's not as readily available, and there is a cost factor, of course. So for me, I would use it for complex lesions. So calcified lesions are definitely ones that I try to use, because sometimes you overestimate the calcium by just angiography alone, and it actually simplifies your procedure. You realize, oh, I just can take a cutting balloon and I should be okay. And sometimes it's the other way around, where you start to realize that, no, I need to plan and strategize this procedure a little bit more. So for calcified lesions, for sure, and left mains, those are the two subsets that I would use it for in a more stable patient. In acute coronary syndromes, I would use it in patients in whom you do an angio and you can't identify the culprit.
Oh, okay.
So I would do it there to just see, am I missing a thrombus that can't be seen by angio alone in a certain vessel, and so on. So those are the real, if I have to limit my use, that's going to be the use.
Okay, thank you.
Chris, do you have a question?
Hi, Chris Jenkins. Hey, great talk. I have a question. I don't have a question, but there was a comment that you made earlier on the use of OPN balloons. In OCT, you can know exactly where to place that balloon so you can get the optimal result of expanding that vessel with calcium nodules. You mentioned with OCT, you place it, towards the edge of the nodule, so you can, you get full expansion of it. Because we've seen, time and time again of, you're working really hard to try to open up this vessel, try to do calcium modification, and you've done some atherectomy, you've done some shockwave, and then when you use OPN, you really want to get that full expansion. So I thought that, with using OCT, I thought that was kind of an interesting comment that you made there. Otherwise, it was a great talk, great talk. In your practice, are you using OCT more so than IVUS?
Yeah, what's your percentage, maybe, and maybe some for the fellows? When do you prefer one over the other?
So IVUS for me is the quick and dirty. I mean, it's just a much faster procedure to use. I prefer it in bifurcations, because honestly, in bifurcations, my whole need for intracoronary imaging is really sizing and landing zones. And IVUS is beautiful for that. And it's much quicker as a setup and much quicker for my cath lab team, as opposed to getting your assist device for OCT and, checking it and doing your injection and so on. So for in all fairness, and I know there are a lot of people who use OCT for bifurcations, don't get me wrong, they can be fantastic. But personally, bifurcations, my go-to tends to be IVUS. For left main, my go-to tends to be IVUS. Again, although there are some experts who are now putting guideliners in and doing OCT to inject for left main imaging. My uptake, I would still say maybe a quarter of my cases I don't do imaging at all. But those are very rare patients that either I'm rushing, to be fair, or patients with focal disease. The majority, 75%, do get imaging, and the most of my imaging would be OCT at this point. I've shifted. I used to be more IVUS, except for bifurcation. So bifurcations, I'm still a IVUS user.
Okay, great. Mirvat, so just so you know, our center is very imaging heavy, I would say. We believe in imaging, so we actually made it a quality metric, and we look at it every month, and we 85 to 90% imaging across our PCIs. So for the whole sort of hospital center, so we're such big believers. However, they are still, when I talk to people, and whether it's internally, externally, there's still some hesitancy or reluctancy around intracoronary imaging, right? So a couple of the things I hear, and I'd love to hear a response, is, so the one thing I often hear is that because of imaging, we are overexpanding vessels and we're causing more perforations than when we use angiography alone. Any comments?
So we have to learn how to size, right? So that's part of getting comfortable with imaging. Yeah, I have seen that, you're right. And I think the problem is that people use the EEL and then don't downsize. They don't round down to the most appropriate. So you saw the case that I showed you. We ended up with like 3.6, 3.7, 3 point something, and we ended up using a 3.5 balloon. So I think you have to get proper measurements in the right place, and remembering that the proximal reference is not your distal reference, which is often smaller. And then rounding down if you're using EEL, and if you're using the lumen size, that should be okay. The other thing is just look at the stent platforms that you have. Most of them will expand, and if you want to be conservative because you're concerned about calcium specks here or there, you can use, for example, an onyx stent that has a really nice range, and then post-dilate after you do an IVUS in between and see. Yeah. And let the malapposition and expansion guide you.
Absolutely. Well, I think, the other thing is, I think people have to remember OCT, IVUS, FFR, all these are just tools that help us, but you still have to use your brain in the cath lab. And like you said, you still have to look at the imaging and take the information, use it. And we can use information well or badly, but I think thanks to you today, we have a little bit more insights on how to use this information to better our outcomes. And because in the end, I think it's the physician using how they use the information. So I thought your talk today was really eloquent and very didactic, and will hopefully give our team and everybody who listened some great tools of how to use the information well to get great outcomes. And as you heard from Antonella, continue doing everything you're doing. You're a role model for many, many people, and we love having you on Monty Heart.
Yeah,
thank you for having me.
Have a great day.